Welcome, everybody, to this PCR webinar on how to approach the challenges of large annuli in TAVI. Our learning objectives today are to understand the challenges in TAVI in patients with large annuli, to learn how to choose a TAVI device in this subset of patients, and to know how to implement lifetime management in treating patients with large annuli. My name is Tanja Rudolph. I'm an interventional cardiologist from the Heart and Diabetes Center, NRW Bad Oeynhausen. And here with me are two experts in the TAVI field. Dominik Buckert, University of Ulm, interventional cardiologist, and Andreas Schäfer, cardiac surgeon from the University Heart and Vascular Center in Hamburg. When we talk about patients with large anatomy, we basically mean patients with a large aortic valvular complex, which includes a large aortic annulus, but also wide sinuses of Valsalva and a rather large sinotubular junction. In most of the patients, we also encounter an elongated aorta. So far, there is no consensus on the definition on large aortic annulus. However, most recent publications rely on an aortic valve area above 630 square millimeters to address a large aortic annulus. So here in this slide, you basically see what aortic areas we can cover with the currently available TAVI devices. And before we start with the two cases we have preferred, we would like to engage you to interact with us. And we would like to start this with the first poll question. So my question to you at home is, what is your preferred TAVI device to treat a patient with a large annulus? Is it A, a balloon expandable valve, or is it B, a self-expanding valve? And so we already got some answers back, and it's pretty, I think the self-expanding valve actually is currently the winner. It's changing a little bit, but it's almost 50-50 between our audience to choose a balloon or self-expanding valve in patients with a large annulus. So the second question would be, having said that, what is your preferred TAVI device to treat a patient with a large annulus and an LVOT calcification? So does this impact the choice of the TAVI device? So again, please choose either a balloon or self-expanding valve in this setting. And here I wait for a few seconds to get the answers. And here now 67% of the people would go for a balloon expandable valve and 38% for a self-expanding valve, despite the LVOT calcification, where we all know that this might be a risk for annular damage. Okay, so please interact during the whole webinar with us. We are happy to take your questions via the Slido app and try to answer them when we have time for that. And now I would like to also highlight that we have challenges when we treat patients with a large annulus and self-expanding valve. There is already some literature available, and we know that when we treat with a self-expanding valve, the rate of PBL is higher. In large annuli, the rate of a permanent pacemaker is higher, and we might encounter the problem that we have to reposition and recapture the self-expanding valve more often than in a normal-sized annulus. However, so far, there is no impact on these features on clinical outcome regarding mortality and stroke rate in these kind of patients. And now I would like to hand over to Dominik to present his case.
Dear Tanja, thank you very much for the introduction and thanks for having me in this interesting webinar. We've prepared some cases and I'm the first one to lead you through my case, which was a 83-year-old male patient that presented with progressive dyspnea, was in a New York class 3 at the time we treated him. Obviously, he had severe aortic valve stenosis, a high flow, high gradient situation, despite a moderately reduced left ventricular function and concomitant severe mitral valve insufficiency. You also see that this patient suffered from several relevant comorbidities. The most relevant, I guess, is that he was on kidney replacement therapy for about 10 years before the actual event. Another interesting thing coming with this patient is his already pre-existing bifascicular block. So we challenged this and were prepared for a high risk of permanent pacemaker implantation, but we will come to that in a few seconds, I guess. So all in all, from the clinical aspects, a typical TAVI patient. This is the summary of the CT features that this patient exhibited. So let's call it the planning summary. You see that he has a large annulus, an area of about 650 square millimeters, or in other words, a perimeter-derived annulus of 29.1 millimeter. It's a classical tricuspid aortic valve with severe calcification, kind of symmetric, nice calcification, and no relevant subvalvular LVOT calcification. What always is reassuring for me is that the other dimension of the aortic valve complex are quite similar. So we have a kind of tubular design with an LVOT diameter of 29 millimeter as well. And you see what Tanya already has mentioned, that in these patients with large anatomy, we encounter elongated aortic situations, which also lead to a kind of horizontal situation. The other aspect of the planning is the access routes, or the possibilities we have there. And you see in this overview of the whole aortic situation that we encounter severe tortuosity of the iliac arteries, both on the left and the right side.
So maybe, Dominic, you allow me to jump in here. I think, as you pointed out, the tortuosity is quite heavy here. So what are your thoughts about planning the procedure when you see an anatomy like that on CT screening scan?
Yeah, tortuosity is one aspect. The other aspect is, are there any relevant stenosis? Is there heavy calcification? And are there calcified stenosis? And when there's summation of problems, then it really gets tough. In this case, we have severe tortuosity, but we don't see real stenosis, and the calcification was quite moderate. So with only having to challenge one of the three problem complexes, I think it's quite suitable for a TAVI procedure, and even for a non-sheath-driven TAVI procedure. So I'll come with this in mind to the case up we used, and you see on the right-hand side of the slide how our setup was in consideration of what I've already told you. And we went for the TAVI access site on the left iliac artery because we considered it a little less tortuous, but already had in mind that we perhaps need an escalation strategy, and our escalation strategy would be to go for a 20F gore tri-seal sheath, which is really suitable there to guide our procedure, but to give it a try with the Navitor 35 millimeter in first place and then see how it happens. With respect to the other exercise on the right femoral side, this is our angio access side. We initially used the reinforced Eros sheath because of the tortuosity there to have control over the pigtail movement, and the radial right side at our center is reserved for a cerebral protection device. Other important features we wanted to pre-dilate with a 28 millimeter balloon and use the Safari S wire as our standard wire for this valve, and place the transjugular pacemaker because of the high risk of total AV block. Otherwise, we more or less stick to wire pacing, but in this case we wanted to be sure because the risk was considered that high. So then we jump right into the case which we recorded a few months ago, and this is only a short sequence coming from the whole recording of the case, which shows you the excess sides and shows you the nice tortuosity depicted with the wire behavior quite exactly as it was on the CT scan. Then we always do a root shot in advance to check whether the angulation of the CT is right. The projections coming from the CT planning sometimes a little bit off in the real patient situation, but we were quite happy with that. So this is a tricuspid view. We do only one root shot in tricuspid and then rely on the projected angle for the cusp overlay when it fits the tricuspid anatomy. What we also want to see is how the wire behaves, and you see the Safari wire making this quite big curve sticking to the outer curvature and has this nice harmonic shape in it. So next thing, and it's a very relevant thing in TAVI, especially in large annuli, is an effective predilatation. So as I already said, we used a 28 millimeter balloon, and you see that the balloon more or less is fully expanded. There is a little bit waste where there is still a waste where the calcification is, but I think we achieved a good pre-dilatation and preparation of the lesion up front, the actual TAVI implantation. So here again, you see the sequence that was recorded, and you also see, and we talked about the access route, that even with the Safari wire and a little bit pull on the wire while processing the valve, the vessels straighten up very nicely, and the actual passage of the valve through the iliac situation was no problem at all. So this was easier than we expected. We were happy with that, but actually this was not that big problem at all. Coming back to the valve implantation, this is our starting position. You see that we can place the valve nicely with regard or in respect to the cusp overlay technique, where we depict the deepest point of the annulus with the pigtail catheter, and the bottom of the pigtail catheter is placed right between the marcus and the end of the stent frame. What you also may see, I will tell you that, we have tried to get rid of most of the tension coming from the system, so we pulled the wire a little bit back and let the whole valve enough time to stay in place. And you see that already here we have a rather stable situation. The valve system is moving with the aortic annulus quite nicely. And so we proceeded and went for the first deployment. It took our time, and we tried to do as much nothing as possible. So we just let the valve do the work and try not to manipulate in any way. And you see at the end of the deployment that the stent frame at the pigtail side didn't actually move. So it was quite a high situation, so we have to check that. And we went for another projection, went to LAO, get rid of the parallax, and checked valve position. And there you can also see that the valve height at the LAO or left coronary cusp is quite good. So it's between the marker and the end of the stent frame. We were quite happy with that, but it's a high situation. And in this high situations, with the valve still connected to the delivery system, you have to be very, very careful that nothing bad happens. So we took our time, hemodynamics were perfectly fine, went back to our cusp overlay view again to double check whether the system has moved in any way. And after a certain amount of time, we thought we can do that. We can deploy the valve here. Went back to our LIO situation and proceeded. And it took our time. Pulled the wire back so that there's no tension or forces coming from the left ventricle. You see that the valve really nicely sits where we wanted it to be. So again, we checked the results. This is the cusp overlay projection again. You see it's high, you see a minimal trace of paravalvular regurg, which is not relevant to me. And here in LAO, again, nice high situation, nice high implantation, only very little paravalvular regurg. So we finished the procedure right there. This is the hemodynamic and paravalvular regurg assessment coming from the echo. Perhaps it was a little bit fast in the beginning, but you see single digits for mean gradient, a mean gradient of 9 millimeters of mercury, and no relevant aortic insufficiency at this point. So how was the follow-up during the hospital stay, where it was an uneventful course. There were no other problems we had to encounter, especially no need for pacemaker implantation, despite the pre-existing bifascicular block, and so discharge was could be performed on the third post-operational day. Thank you very much.
Yeah, Dominik, thank you so much for this great case presentation. I think everything was very straight implantation, even though you might have thought that the access could be a little bit more challenging. And you already mentioned the pre-dilatation, so maybe we focus a little bit on that. So you said that you think it's an absolute clear prerequisite. Can you imagine any situation where you omitted enlarged annuli anatomy, or do you think I always go for it?
When I do a self-expandable valve, I always go for it. I think there's no reason for not doing it in this situation with a self-expandable valve. The self-expandable valve needs time, and because of the time it needs to deploy, it has a lot of time to move in a direction in which we don't want it to move. And a nice preparation of the lesion is necessary to have the compliance of the aortic valve anatomy and complex to follow the deployment movement of the valve. So I think there's no real situation in which I would not predilate. It's rather a question of how to predilate to be effective. But perhaps Andreas could jump right in. How do you do that in your clinical practice?
Yeah, I totally agree. Thank you for the question. First of all, congratulations to that very smooth and nice case. It was really straightforward, really nice implantation, and especially the fact that the patient was not in need for a permanent pacemaker implantation with the prior diagnosis is really impressive, and is most likely due to the fact that you chose a very wave and high implantation rate, which is good. So I think there are several things we can learn from this case. I think first of all, I totally agree, proper pre-dilatation with a properly sized balloon, which in my opinion means 1 or 2 millimeters below the aortic annulus diameter is of paramount importance to prepare the aortic valve complex properly. Secondly of all, I think we have to talk about the reasons why this case was so smooth, right? I think one major fact in your case was that we had another flared LVOT. So we had a tubular LVOT, which was in line from the diameter-wise with the aortic valve. So the valve or the catheter system had not the chance to dive really deep into the LVOT, right? This is really one important point which leads to success in large aortic annuli and which you have to have in mind when you plan those procedures. And I think the second point we have to think about, and which also was really nice in your case, is that we have in these large annuli with these large valves a really long deployment process. And what that means is that we have often a late contact of the valve stand to the aortic valve anatomy. But in your case, you had a really nice curvature of your wire and a really good contact on the outer curvature to the non-coronary cusp. So you made early contact during the deployment process to the non-coronary cusp and therefore had all of the time a very stable position with this valve. Yep. So I think that are the key factors to a good and successful TAVI in large annuli. Also, those key factors are not really changeable by us. You know, that is the things that are given by the patient. Yep. And if we are lucky, we can do it like you did. And if the anatomy is not so advantaged, we have to think about other solutions.
Yeah, I totally agree on that. We can't change it. Sometimes it's even hard to assess it upfront. I think you made a really, really good point that the whole complex anatomy matters. The complex coming from LVOT, actual annulus, ascending aorta, even aortic arch. Is determining on how the catheter will behave, and this then affects the actual implantation. And sometimes you get an idea coming from the CT and coming from the anatomy you see, this will work out or this will not. But it really is hard to judge upfront how the system or how the actual implantation will work out.
To agree, especially since those patients often suffer from accompanying orthopathies, yes. Right? So this is another point which makes it often difficult to place those valves. Yeah, absolutely.
I think these are all very important points, and as you already mentioned, the two of you, you can only estimate it from the CT, but you can never be 100% sure how the aorta and also the whole vasculature really reacts to the wire in the end when we start the procedure. So we have a few questions from our audience, and one question is, I think you mentioned it very well during your presentation, but maybe you can summarize once more what views we definitely need to implant the Navitor valve. So what is key here?
Okay. I think, first of all, it's good to have a tricuspid view as a starting point. So you need to know where you have the tricuspid view. Actually, with the self-expandable valves and the Navitor is no exclusion to that. You always have more or less parallax of the valve system with regard to the actual annulus. But you know, you need to know where the actual annulus is. So to start from that. And to start from that, the next thing is a clear cusp overlay view to have really the deepest point of your annulus depicted and visualized. And coming from that, you can start the deployment, and you can start a high deployment if you want to, and if you want to be brave, as you said, or you see that you need to do it. And when you have the valve open, the hemodynamic situation usually is very stable. So you have your time, and you can change to an LAO view. Normally, it's not in the area of the tricuspid view, so you have to check it on site, let's say. And what you have to do there is to get rid of the parallax of the valve system. You only want to look at where does the stent frame end in comparison to the aortic valve annulus below the left coronary cusp. And there you have to assure that at least some material of the stent frame is below this point, because if it's not, then you have a very, very high risk of a pop-out, because then you have a hinge point where the further deployment will lead to at least a partial pop-out of the system. So to summarize it and make it more clear, tricuspid view to know where the anatomy is, cusp overlay to know where you can place your device in comparison to the deepest point of the annulus, then go to LAO with getting rid of the parallax to see if it's there below the annulus as well. And these are the three crucial steps.
And I guess you tried to implant the valve rather high in order to omit permanent pacemaker implantation.
Yes.
Is this what you had in mind?
Yes, we definitely had it in mind. Our thoughts on that is, when you can avoid a permanent pacemaker, that's a good thing. But it's not the only thing you should aim for. So to have a risky implantation, just to minimize the risk of a permanent pacemaker and put the patient at risk for other serious adverse event is not a good idea. But during the first deployment, and it was the first deployment, it was the first approach, I think you can start rather high and see what happens. And when the system is stable, the valve is stable, it hits the left side, the LAO side, quite nicely with respect to height, then you can use it. When you see during first deployment that doesn't work, of whatever reasons, then you have to change your approach or adjust your strategy. So at this point, I wouldn't go so far to say to avoid a pacemaker, I would put the patient at risk for other serious events.
Another question here from the audience is whether the choice of a balloon expandable valve would result in a lower risk in this setting for permanent pacemaker implantation.
Data says yes. I think that the statistics are true, but it's possible to have reasonable pacemaker rates with self-expanding devices as well. I think just looking at this particular point, especially in large annuli, balloon expandable valves have lower risks. Whether the patient with a balloon expandable valve would have had the need for a pacemaker implantation or not, I don't know. We don't know. We did it like that. I'm quite happy with the result. There were other reasons for us to go for that device, and it's always a trade-off between several features. With regard to pacemaker, yeah, balloon expandable valves have some advantages.
Yeah, I think I absolutely agree, and maybe I can ask Andreas one last question. So when you see this implantation, which was rather high, and we discussed why Dominic tried to achieve this kind of position, would you be afraid in such a case to do a post-dilatation if necessary? It's also a question from the audience.
No, not really. It really depends on the calcium load of the aortic valve complex. If there is really a proper amount of calcium, which is, by the way, also a prerequisite for implanting this valve so high. If there's a proper amount of calcium and the valve is properly anchored, you can always go for a post-dil. That is no problem at all. But you really need a good rapid pacing, of course. There shouldn't be any left ventricular action during that procedure, and you should place it at a rather high. And if you have a smaller LVOT than the aortic valve complex or the aortic annulus, then you have to be very careful to place the balloon not too deep into the LVOT, because by that you can produce a pop-out. These are things to consider when post-still in those high positions. But generally speaking, it is no problem.
And maybe one last question for you. Why did you use the cerebral protection device? Is this just your default strategy in your center?
Yeah. To answer that shortly, because then we would have another webinar and another discussion going on. It's institutional standard to do so in every case, and because of that, we did it in this case as well.
Okay, great. So thank you so much for this very educational case, and I think we will move on now to Andreas Schäfer, and he's going to present a different case. So we'll see what we learn from there.
Thank you, Tanya. Thank you. So I think the case I will present now is a case which really nice illustrates the challenges we can face in TAVI and large aortic annuli. And compared to the case just presented by Dominik, it was a little bit more complicated. So this was a 75-year-old male patient, also with severe aortic valve stenosis, high flow, high gradient. The patient suffered besides from atrial fibrillation, left bundle branch block, and severe COPD, sarcoidosis, and arterial hypertension and obesity. So also after the old guidelines, we have to say after last week, it's a borderline patient. Age-wise, it's not a good patient for surgery. So this is clear. So this is the CT diagnostics prior to the procedure. So moderately calcified aortic valve complex. The perimeter-derived annulus diameter is 29.8 millimeters, so nearly 30 millimeters. But in this case, different to the case presented by Dominik, the LVOT diameter is 32.2 millimeters. So it's a really flared LVOT compared to the aortic annulus. And what we also saw was significant LVOT calcification under the left coronary cusp. A little bit curved peripheral vessels, not as much as in Dominik's case, and no significant calcifications of the right iliac artery. So we wanted to aim for an intraannular valve because this is a comparably young patient with 75 years old. And we also saw LVOT calcification under the left coronary cusp. So we went to proceed with a Navitor valve. This is our standard approach in our institution. It's a single ultrasound-guided femoral puncture. In this case of the right side, we use a multi-close approach, which means one prostyle and one femosseal or angiosseal, depending on the operator. The second access is the right radial artery, and we also used a Safari S-wire. We also used a two-dilatation balloon of 28 millimeters and a Navitor Vision 35 millimeters. And I will now guide you through the procedure from the point after the pre-dilatation. We now bring out the balloon at this point of the procedure. The Safari wire is already in place in the left ventricle, as you can see. Temporary pacing is also conducted through the right jugular vein. And after removement of the sheath, the Navitor prosthesis is coming into the patient. And if I may draw your attention in a few seconds to the upper side of the monitor, then you will see as I advance the catheter system now, the aortic arc angle is very steep, very steep. There's no really curve in this anatomy. It's a really steep angle, and this will lead to problems during the placement of the valve later on. So this is the first placement attempt. This is already the cusp overlap plane. And as you can see here, we already starting very high because we're anticipating, in fact, diving of the valve because of the flared LVOT, which is a problem in large aortic annuli. So now we are deploying the valve, and what you also see is that we are not really nicely on the outer curvature of the ascending aorta. So we are not making early contact with the non-coronary cusp, which gives the whole valve system a pretty good chance to dive and to walk into this aortic valve complex. At this point, we think the non-coronary cusp shape is good, but now it's diving into the LVOT, which results in a much too deep position. I think we can all agree on that. This is too low, this is too deep into the LVOT. Nevertheless, we're doing a root shot here, but this confirms our impression. So we are resheathing the valve, which takes a little bit longer with a 35 millimeter valve size. And do a second attempt to place the valve. So now we are bringing the whole valve back into the sheath. It's a long way to reach it. As you can see, my colleague Niklas Schofer from cardiology is turning the knob. And now the second attempt, starting even higher. And what we want to do now, and what we try to do, is to push the wire and the whole catheter system into the aorta to bring the valve system more to the outer curvature. But due to the steep angle of the aortic arc, the whole force just transitioned into the aortic arc, but not to the valve system itself, resulting in this, what we see here now. It's okay at the non-coronary side now. Now it's locked, but at the root shot, we still see a much too deep implantation at the left coronary cusp, which is now confirmed in the 3-cusp view. So what we did, we went back to the cusp overlap plane and brought the valve back into the catheter for a second time, which you can see here now. And maybe we should stop here for a second.
Yeah, because now I wonder, Andreas, what we see here now on the screen at the ventricular end of the Navitor device. So maybe you explain this to us.
Yeah, no problem. So this, to be clear, this is a totally resheathed valve at this point. We couldn't resheath the valve anymore. But what we see is that one stent strut, so one part of the stent frame, which is pointing to the side of the non-coronary cusp, is not going back into the sheath. So this is an event which can occur with a large Navitor valve, which is also already acknowledged by the company, which are currently on the way to produce a new catheter for this big or large valve. But this is a potentially dangerous situation, to be honest. So maybe I can ask Dominic, how would you tackle the situation?
Yes, yeah, you named it. It's dangerous. It's a situation in which you have to have a strategy on how to go on. So in your case, the good thing is that the valve still is below the aortic, below the valve annulus. If it's up in the aorta ascendens, in the ascending aorta, you can't go further anymore because you can't travel through you can't do the passage of the valve with the partially flared prosthesis like that. You cannot apply more force to try to get the valve into the catheter. This can lead to a broken catheter, damaged system, and you have no control at all. So actually what I would have done in this situation where the valve is below the annulus, I have control about the situation, is to proceed and to feel the urge and the force that is produced by the situation to actually implant it here.
Yes, I totally agree, Dominic. So we are under the valve. This is good. What we really have to emphasize this: if you are faced with that situation, you don't want to start all over again by bringing the valve up into the ascending aorta and start a new implant process. This can lead to catastrophic complications like dissection of the aorta, and you also cannot bring the valve out of the patient again because it won't go through the iliac vessel that way. So what you want to do now, and you must do, is implant the valve. And that's exactly what we did. We did this third attempt. We accepted the position we had, which was fine on the non-coronary side, and which was too deep on the left coronary side. We have to be honest here, that's a too deep implantation. We brought it a little bit up, so non-coronary it's perfectly fine. It's the 3 millimeters we want with these radio-pack markers, as you can see it, and brought it in. And after all, I think this, from all 3 attempts, that is still the best position we could get. And maybe what we also have to emphasize is that with this particular valve, you have no hemodynamic compromise during the whole procedure. So you can resheath as often as you want. The patient won't feel it because we have a full functionable valve during the whole deployment process. So we slowly deployed the valve in this position. As you can see here, my colleague is slowly rotating the knob and accepted this position, which was, as I already said, very good at the non-coronary side, too low on the left coronary, which is confirmed by a wood shot in a few seconds. You have to have a good look at the 3 retainer tabs if they are all free, and after that you can remove the valve system and bring back the wire into the left ventricle. And next thing we see is aortic wood shot. And as you will see, we still have, and that is not totally unexpected because we won't have the skirt, the sealing skirt at the outer side of the valve stand exactly at the head of the aortic valve annulus at the head of the left coronary cusp, as you can see here. And exactly there, we have a significant paravalvular leakage. So what we did, we went in for post-dilatation using the same balloon we used for the pre-dilatation. So it was a 28 millimeter true dilatation balloon, to remind you, and did a post-dilatation. And a little bit surprisingly, we nearly completely eradicated the paravalvular leakage, as you can see here. So this is maybe a trace paravalvular leakage. So the postoperative course, the patient already suffered from atrial fibrillation and left bundle branch block, and not surprisingly, with this deep implantation head at the left coronary cusp, the patient required a permanent pacemaker implantation. But apart from that, the postoperative course was uneventful. The patient was discharged home on postoperative day 4, and the valve hemodynamics are really outstanding. One has to say the transvalvular mean gradient was 3 millimeter of mercury.
Yeah, Andrea, thank you so much for this very illustrative case. I think it demonstrates very well that we have to watch out for challenges during the implantation in large anatomies. And I mean, would you have thought that you encountered these kind of problems just from the CT scans, or were you already aware of the problem when you looked at the CT scan?
Not completely. So there's a multi-part answer, obviously. So I anticipated a diving behavior of the whole valve system because of the flared LVOT, no doubt about that. That was a little bit foreseeable, but that we couldn't apply force to the valve system, which really transitions to the valve in the aortic annulus, that was surprising for us. And that was the steep aortic arc angle, which was bad luck, if you will so. So that we were not able to bring the valve to the outer curvature and to make a early contact to the non-coronary cusp. That was a thing we didn't expect. And in combination with this flared LVOT diameter, that combination made the procedure really, really difficult. Yeah. But the hemodynamic result was very, very good.
Yeah, and I think you demonstrated very nicely here that, of course, if you have a challenging anatomy like that, you might even encounter additional problems that somehow force you to go on and fulfill or deploy the valve in the end, even though it might not be the super perfect position. But I think in the end you had a great result, and also shows us that somehow the valve is somehow a little bit forgiving. So even though 1 or 2 millimeters more or less does not really result in a bad result here for the patient. I mean, what I really liked during the case, and this was shown during with the pressure tracing you had here, that the patient was stable all the time, and the patient, I think, had already reduced ejection fraction. Is this something you usually encounter in patients when you treat them with the Navitor?
Yeah,
is this
absolutely.
What regularly happens?
I think this is a big advantage of this valve platform, and this is especially true for patients with reduced left ventricular ejection fraction, obviously. So in other valves, which with the supra-annular valve seating, we have this obstructing phase during deployment, right? And we all know those patients which are not so forgiving, especially when you are when they do a second or third implantation attempt. So these are patients which sometimes have to be resuscitated because of these longer phases of an obstructed LVOT. And especially in those patients, this valve has really its advantages because you can implant as often as you want, and the patient won't feel it because hemodynamics are totally uncompromised by the valve system. So I think this really makes also the decision process in our clinic. If we see a patient with a severely reduced ejection fraction, which is in need for a self-expandable valve, we would rather go for an intra-annular self-expanding valve because we know that the procedure will be much more smoothly because of the stable hemodynamics.
And maybe one other question I would like to ask you. This is now a little bit younger patient than the first one we saw, 75 years old. And I think here in this subset of patients, we think a little bit more about lifetime management. So maybe you can highlight some thoughts you have on this TAVI platform regarding lifetime management aspects.
Yeah, absolutely. So I think it's imperative to proceed in young patients. You can define young patients as you want, but I would say 75 and below. And if they need for a TAVI procedure, you should aim for an intra-annular valve. I think this is really important for revalving or TAVI and TAVI, you name it, because we will have in the future, we will have more TAVI and TAVI procedures. And if we have an intra-annular platform as index valve, and we have a lower risk of coronary osteocclusion during TAVI and TAVI procedures. And we will have maybe also a better platform to implant then a supraannular valve. So I think these are major advantages. Besides from the fact cell size is maybe also a fact for coronary ostea approaches. Maybe you can both comment on that as cardiologists a little bit more. I think this is also an advantage in this particular valve.
In regards to hemodynamics, since this is an intra-annular valve, do we lose anything here compared to a self-expanding valve with a supraannular design?
So we don't have really data on that, to be honest. In my clinical experience, most of these patients leave the clinic with single-digit transfemoral mean gradients if you use a self-expanding intra-annular valve. So the hemodynamics are really good, which should be also a prerequisite for implanting it at the first place in young patients. If I would have the feeling that the hemodynamics would be inferior to supraannular self-expanding valves, I wouldn't go for it in young patients. But in my opinion, it's not.
So we were discussing a lot about large anatomy, and of course it comes to my mind that if we have a patient with a large anatomy, maybe this patient has not a tricuspid valve, but maybe a bicuspid one. And so, Dominic, I would like to ask you, is this something you search for when you have a patient with a large anatomy? And how do you approach this topic in your daily clinical practice?
Yeah, thank you for the question. It's a really, really relevant one. When you have certain red flags coming together, relatively younger patient, large anatomy, male patient, high gradients, a lot of calcium, that leads the way to a bicuspid anatomy. And how to treat a bicuspid anatomy is something that needs to be discussed in the whole team. Different approaches, different aspects are necessary to take into consideration. But the first thing is, and I think this is really, really key nowadays, is to be aware that there are not just simple tricuspid anatomies and simple CVAS 0 classical bicuspid anatomies, but there's a lot of things going on in between. And the awareness that this is possible has to be there, and it even has to rise in this complex situation, as I pointed out, when several factors, several red flags, let's name it like that, come together. And so for a 75-year-old patient with severe aortic valve stenosis, high grade calcification, I would definitely recommend to actually search for a bicuspid anatomy. And when you think you have one, it's not that easy to have consensus in all times, but when you think you have one, you need to have a good partner, namely the cardiac surgeon, to evaluate with you together what is the best option for this patient. But Andreas, as a cardiac surgeon who performs both procedures, may add the most useful information there.
Yeah, so generally speaking, I think young patients with bicuspid aortic valves, if they are suitable for cardiac surgery, they should be operated on. Yeah, I'm convinced by that, because you can cut out all the calcium, you can circumvent some complications you can produce by performing TAVI in those patients. However, we must also say that current data of TAVI in bicuspid aortic valve anatomy is really good. So this is a consequence of better techniques and valves and so on, you name it. But it's also, and I'm convinced by that, a consequence that we now know which bicuspid valves we should provide with TAVI and which not, which should go to surgery. Because as you all know, one bicuspid valve is not like the other bicuspid valve. We have these two bicuspid valves with not much calcium, no wafers. These are very good approachable by TAVI. And we have these severely calcified aortic valves with severely calcified wafer, which then, if combined with a tubular STJ, can lead to catastrophic complications during TAVI. So I think if a patient is suitable for surgery, he should be operated on. But if not, TAVI is a good alternative to provide those patients. Also, things like paravalvular leakage or permanent pacemaker implantation may have a little bit a higher weight than in tricuspid anatomy.
Yep.
And would the two of you agree that in bicuspid anatomy, even though it might be a small anatomy, and we also encounter that from time to time, it's absolutely necessary to predilate, because usually we have a different sort of extent of calcification, but also the symmetry is not as it is in a tricuspid, and usually I would say to prepare the valve to get a good landing zone is even more crucial.
That's a really, really good point. So I think predilatation, was your point, is totally crucial, because if you have a calcified wafer, you have to crack it open somehow, a little bit widen it. And if you do your measurements in bicuspid aortic valves, which is also an art for itself, you should really take care of measuring not only the aortic annulus, but also the valve opening area 3 to 4 millimeters above the aortic annulus. And if you do that, you're often surprised how small the actual opening is. And if you don't do that, you can end up with a much too large valve, and this can end up in really severe complications. So you really have to have experience with TAVI in bicuspid anatomies. It doesn't matter if it's large anatomy or if it's small anatomy.
Yeah. I want just to add, first of all, I agree. Predilatation in this case is very crucial. And for another aspect as well, with the balloon, you learn somehow how the valve will behave. And when you have this, as you mentioned, the severe raphe calcification, and you see that this slit-like opening remains slit-like, and the balloon cannot do anything about that, then you have to really think: is it good what I'm trying to do? But because when the balloon cannot open the valve, the self-expandable platform won't either. So that's something you learn during the procedure and get some information that are useful for the proceeding. And sizing, you mentioned it. It's not exactly the topic of our webinar today, but sizing in this case is really challenging and multifaceted. So you have to have experience with this situation. I totally agree on that point. First of all, to make this point, awareness is the key thing. Look at the patient, look at the CT, think about it, try to understand the anatomic dimensions, and then judge what can you do.
Yeah, I think that's very important. Maybe have a few minutes left, and we could address one question that also came up from the audience, and this is extra large anatomy. So I have shown you a slide what areas, aortic annulus areas we can cover with the devices, which is in the IFU. So what do we do if it's beyond that? Maybe Andreas, a short answer to my question.
Short answer is, if the valve is really calcified, you can even go with self-expanding platforms a little bit higher into the diameter, maybe 31. And with balloon expandable valves, you can really play with the filling of the deployment balloon. And we have experience with overfilling of the deployment balloon up to 5 milliliters and 29 millimeter valves, and we provided patients with aortic annuli up to 32.4 millimeters in dimensions, aortic valve dimensions. So this is possible, and usually the results are really good.
And I mean, we even have data on extra large anatomies showing that this is really a good approach. So there are publications out even showing that this is a safe approach we have. And it might even be that most of the valves still have this safety margin still in there, that we are still somehow oversizing a little bit the valve in every single size. So at least this is what we anticipate from also the experience I think all of us have made in our daily clinical practice.
Yeah.
Okay, so I think here we come to the end of our webinar. I think we learned that with the self-expanding platform, the Navitor platform, we could demonstrate you with two excellent cases that it works very well in ledge anatomy. In both cases, we saw really great hemodynamics, low gradients, single digits, and also a very low rate of PBL, even though when the implantation position was not the best or the perfect we could achieve. And I think we also learned that there might be some challenges during the implantation. I think in particular the second case showed us this. And here I think it was great to see that when you are experienced and you take your time, you can really get the best result for the patient. And I think it's very crucial, and this is something both of you shared with us, to look at the CT scan up front, really to try to understand what problems might occur during the implantation and somehow anticipate that. What I think we also discussed is that with the platform we were showing you here, it's an intra-annular valve design. It also takes into consideration the lifetime management of a patient, and so we might have a good index valve to plan for further TAVI and TAVI procedure for younger patients. So here I would like to thank my two colleagues, Andreas Schäfer and Dominik Buckert, for contributing this really two excellent, very educational cases, and also for giving very valuable insights into their clinical experienced during the discussion we had. I would also like to thank Abbott Germany to support the webinar. And last but not least, I would like to thank all of you who participated in this webinar and who also were so active via Slido to discuss with us this important topic. Thank you so much and good evening.